Our skeletal system puts up with a lot of abuse over our lifetimes. Eventually, we often must give it a little TLC. Bones and Groans, tonight on call with the Prairie Doc, celebrating our 20th season. Hello, I'm Dr. Andrew Ellsworth. Welcome to On Call with the Prairie Doc, as we move ahead with the celebration of 20 seasons of truthful, tested, and timely medical information. That remains our goal for tonight's discussion of orthopedic issues. Joining us tonight here in our studio on the South Dakota State University campus in Brookings is Dr. Matthew Blake with Avera Orthopedics, Sioux Falls, South Dakota, and Dr. David Jones with Orthopedic Institute, also in Sioux Falls. Welcome, Matt, David.
Thank you.
Thank you.
Matt, if you would tell us a little bit about yourself and your background.
Sure. So I'm not a native to South Dakota. I'm actually a native from South Carolina that transplanted to South Dakota about 4 years ago. Did my training in Richmond, Virginia, and I did orthopedic training in Richmond, Virginia with a shoulder and elbow fellowship at the University of Pennsylvania. I then did a sports medicine fellowship at the University of Kentucky. Moved to Sioux Falls, South Dakota because my wife is from around this area. Been here, like I said, 4 years. My wife and 5 children love it here. I love it here. It's been a great transition for us.
Excellent. Thanks for being here. And David, how about you?
Glad to.
So I did grow up in South Dakota, grew up in Platte, and went away to Indiana, Taylor University for my undergrad training, and then moved to Rochester for medical school and residency and a hand surgery fellowship. My wife and I moved back to Sioux Falls about 8 years ago and lived there with our 4 boys. And I've enjoyed being back closer to home and seeing folks from this area.
Excellent. Good to have you as well.
Thank you.
And I just want to mention, as we look forward to answering your questions about pain and other problems in your bones and joints, call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. And to encourage your questions, those of you who ask a question during the first 20 minutes of tonight's program will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of this program. Your question will remain anonymous, but be sure to provide your name and contact information when you submit your questions so we can contact the winner. Just today, I had a guy with some shoulder problems. And so, Matt, that's your thing.
Yes.
And I'm suspecting a rotator cuff injury. He got it stuck and was trying to yank it out. I mean, there's all sorts of reasons to hurt your rotator cuff.
Yes.
What is the rotator cuff?
It's a good question. The rotator cuff is a group of 4 tendons that go from your shoulder blade across the ball and socket of your shoulder that attach right next to the ball of your shoulder on your upper arm bone. Typically, people who have rotator cuff problems or injuries, they have pain that they experience pain in the side of their shoulder. Sometimes that pain in the side of the shoulder goes down to their elbow and makes it difficult for them to move around their shoulder, to reach and lift and get their arm usually above their head or out to the side.
What are some of the ways they cause an injury in the first place with the rotator cuff?
There are a lot of different ways to injure your rotator cuff. One, like you just said, you reach in, grab something, and try to jerk on something really hard. I had a guy this week in clinic that he was trying to carry his elk that he just shot and was trying to get it ready to clean, and he grabbed the elk and jerked on it and felt something rip in his shoulder. So that's one way. I've seen people putting on Christmas lights, and they slip on their ladder and grab the roof or grab the ladder and to stop them falling and tweak their rotator cuff that way as they fall. Sometimes rotator cuff it's an interesting group of tendons that just sometimes with normal wear and tear in life, the rotator cuff just gives out. The blood supply to the rotator cuff sometimes is not that great. And over just the course of lifetime, the rotator cuff can tear or injure itself just by itself.
So obviously if there's a tear, it's not going to fix itself.
No, not usually. It's very rare.
But sometimes surgery isn't needed if they're having rotator cuff issues.
Correct. There's a lot of times where rotator cuff, because it's a group of 4 tendons and they work together. And even though there's a tear of the rotator cuff, it may be a small tear or maybe a little bit larger tear, but the other tendons of the shoulder can overcome the tendon that is torn. In other words, that if one tendon is torn, or maybe 2 tendons that are torn, just because they're not going to reattach does not mean the other tendons are not functioning. And those tendons that are still functioning can continue to function well, and people can do very, very well with their shoulder even though they have a rotator cuff tear.
So working with physical therapy and strengthening exercises could be helpful.
It's a must. That's number one. If I see somebody with a rotator cuff tear, usually I say the first thing we need to do is get you into therapy. Because sometimes with therapy, even if you have a cuff tear, with therapy and time and anti-inflammatory medication, the shoulder can get back to normal.
Good, good. Between that and surgery, are there any other options for treatment?
Yes. So there's a lot of different things that we have done for treatment of rotator cuff. I like anti-inflammatory medication. If you have an acute injury, an injury that happened just right away, sometimes we do
like ibuprofen.
Like ibuprofen, yep. Like ibuprofen or Motrin or Aleve. Sometimes physical therapy, home exercises versus a formal physical therapy visit works. Sometimes we do cortisone injections of medicine near the rotator cuff to help decrease the pain of the rotator cuffs so that you can go back functioning the way you would like to function.
So then if a person needs surgery, they've probably failed physical therapy or some of these other things. What's the recovery like with the rotator cuff? How long do they have to be in a sling?
So that's a good question. That's a great question. So those are actually 2 questions. The rotator cuff takes time to heal. So what I do is I try to reattach that tendon back to the bone. And it takes time for that tendon and bone to grow back together. So doing that, you're in a sling usually for about 6 weeks. And by the 6-week time, that bone and tendon knitting back together is about 30% as strong as a normal rotator cuff tendon. But then it takes still working with therapy and time and being careful with your shoulder for usually about 5 to 6 months, to fully get that tendon to reattach to the bone so that you can go back and play tennis, play golf, and do the things you want to do. So it's about a 5 to 6 month healing time.
I've had patients or know of patients that didn't keep their hand in the sling and had to have it redone.
Yes.
Do you see that very often?
I try to, usually people, when they have the rotator cuff repair, usually they, at the 6-week mark to the 3-month mark, they say, man, my shoulder feels really good. And a lot of times I have to go, okay, just because it feels good doesn't mean that it is ready to go yet. And there's a lot of times that I have to slow people down and say, okay, you really shouldn't do X, Y, and Z. Throw your garbage up into the garbage or toss the ball with your son anymore. Have I seen it? Yes. But I try to counsel my patients, you know what, let's go slow, let's take the time. If you can wait and you can do this appropriately, you should get back doing the things you want to do.
Yeah. David, you do more with hands.
Yeah.
You took a hand fellowship. And so what's one of the most common hand things that you do to help people?
Yeah, one of the most common complaints that we hear and issues that we deal with is people who are struggling with numbness and tingling in their hands, nerve problems, carpal tunnel syndrome. Arthritis is another common condition. And thirdly, injuries, trauma, broken bones, lacerations, cuts to the tendons, fingers, things of that nature.
Sure. So with carpal tunnel, they've got that numbness, tingling, usually in the thumb and the first fingers. You know, they shake it out and stuff. How do they know for sure if it's carpal tunnel?
Yeah, so it's amazing how often times people don't realize they have carpal tunnel syndrome. They think that waking up at night with your hands asleep is just part of aging. Sometimes people think it's related to arthritis or other conditions, but oftentimes it becomes bothersome enough where it's interfering with sleep every night, driving, talking on the phone, just daily life activities are becoming difficult, and that's when they seek treatment. There are some studies that can help confirm the diagnosis. A nerve conduction study helps to tell us if a nerve is pinched and where it's pinched and how severely it's pinched. So that's a common test that we use in this condition.
And that involves a few needles? And
it is, yeah.
It's not exactly a torture
It's not the
device.
most pleasant test, but most people tolerate it pretty well.
Okay,
Yeah.
good, yeah. What do you recommend for treatment?
Yeah, so for more mild symptoms, oftentimes we have people just start off with wearing a little wrist splint at night. Most of us tend to curl up when we sleep, and when we do, that ends up compressing the nerve in our wrist, which leads to the numbness and tingling, falling asleep feeling. So for many people with more mild symptoms, simply putting a splint on at night before they go to bed is all that it takes. If symptoms worsen, you can do cortisone injections similar to the shoulder, or ultimately surgery is an option.
Yeah. Along those lines, talking about nerves and such, this caller states that she hurt a nerve in her arm a year ago and that the fingers on the hand have not bent well since. Is there a way to fix this issue without surgery?
That's a good question. So there's some information that would be interesting to know. One is, was the nerve repaired at the time of the injury? So nerves, if they are cut, can be repaired, and over the course of 12 to 18 months, that function can return. From a non-operative standpoint, certainly we lean a lot on therapy as well. Hand therapists can work to regain function or to help with adaptive equipment. Ultimately, there are situations where people have nerve injuries where even if the nerve is repaired, the function isn't restored. And in those situations, sometimes we do surgeries where we borrow muscles from one area of the hand to restore function in other areas. So there are options, yeah.
Better to maybe go get it checked out.
Yeah, you bet.
This caller from Minnesota is wondering if you have intermittent joint pain, so it comes and goes. Could it possibly be arthritis, or is that more like symptoms of tendinitis? What would you say to that, Matt?
Yes. It depends. I mean, there are, as you go across let's just talk about shoulder, or you can talk about knee as well. We have tendons that cross our knees. We have tendons that go across the shoulder. And if you have intermittent pain in that area, you definitely can have tendinitis or inflammation of the tendons that is causing pain that is periodic. In other words, the more things you do, the more activity you do, the more stress you put across that joint can flare up that tendon. So,
and of course, the tendon being that connects the muscle to the bone.
Correct.
And
correct.
it inflamed. And you guys are in surgery. Can you see inflammation with that?
Sometimes. Yes, and so there are tendons that you can take a look at, and the tendon looks red and angry and mad, and you can tell, there's some tendon problem there. The other things that we can see is sometimes tendons have a specific shape and kind of feel to it, and when tendons go bad, you can also have tendons that feel and look almost like the consistency of shrimp, because the body's just healing it in a poor fashion. And so, yeah, you can look at tendons at surgery and go, man, that looks really terrible. It looks frayed, it looks red, it looks angry, it looks like it's going to rip, or, yeah, so you can, yes.
Yeah, so of course with tendinitis, they either need to stop doing what causes the pain and let it heal up and calm down.
Sure.
Or maybe ibuprofen, NSAIDs.
Sometimes people, how they're using their body also contributes to the tendinitis. In other words, how they're using their shoulder, how they're using their elbow, and sometimes that's why physical therapy works really well for some people, because their physical therapists can look at them and go, man, you're really holding your shoulder in an appropriate position, or if you try these different activities, that can help stretch or strengthen other tendons that are going through that, so that one tendon that's being bothersome calms down.
David, how is that different from arthritis?
Yeah, I think that question highlights a interesting part of orthopedics. In orthopedics, an X-ray is an invaluable tool for us. The X-ray shows us the bones and the joints, and so many patients, probably most patients that come to see an orthopedic surgeon, end up getting an X-ray, because that's one of the most valuable tools for us as we evaluate, is this a tendon problem or is it a arthritis problem where the joint is wearing out and you're starting to see bone spurs or loss of the cartilage or the cushion between the bones. I think that question highlights the value of X-rays for orthopedic surgeons.
And I think I want to talk about arthritis more because it's such a broad topic, but I do want to go to our first roll-in here, where we've got prosthetic maker and orthotist healthcare professional Andrew Nelson helps provide limbs and braces to those who have undergone an injury or disease. Prairie Doc reporter Esther Michael has the story.
A prosthetist and orthotist. It's a fancy way of saying artificial limbs and braces. So I meet with clients to discuss their injury or amputation and come up with solutions to help them achieve their functional goals. Age can play a part in amputations, usually for vascular disease, for instance. So the diabetic or vascular population that maybe they're overweight, maybe they're not managing their blood sugars to that effect. It tends to be patients that are middle-aged or older, but the cancer and the traumatic patients tend to be younger. There is some age factor into it, but really it's just a determination of the etiology of their amputation and then moving forward from there.
The most common reason for amputation is vascular disease, such as diabetes. While a prosthesis cannot completely replace the intricacies of the human body, technology has advanced enough to provide limb functionality.
I think the biggest thing is explaining a lot of these, especially for prosthetics. Will I be able to do this again, and whatever this is? And a lot of it comes down to, could you do that before? Dunking a basketball, playing the piano, whatever it might be. Explaining to the patient that it's not going to replace what was missing. Our body is so intricate in how it works. And if you were to lose a below the knee amputee and lose your foot, or if you're below the elbow amputee and lose your hand, we can't replace those intricate movements and everything that the body is able to do in its natural state. However, we can create a functional tool to help accomplish these goals that you might have, or these current frustrations that you might have. And through that conversation, it helps them see value in the device and gives them a better understanding of what our goal is and what we're trying to do. We can't replace what's missing, but we can help restore with a functional tool.
Nelson said the company's secret is to start with a blank slate and no preconceived ideas or notions about the patient's needs and desires.
We want to get to know you. What are your goals? What are 5 goals that you want to be able to do? Or what are 5 current frustrations that in the last week, it's hard for me to twist the peanut butter lid off on the jar, or it's hard for me to hold the door open. It's hard for me to walk from the stairs to the bedroom, whatever it is. And through that conversation, it helps them express what they want. It helps us understand what they need. And then we're able to work together, patient or client and prosthetist, to get them the device that's best suited for them versus me giving them all of my great ideas and ignoring what they have to say. So it's been this very natural, organic way of learning more about the patient, which we have to do anyways, but it helps them feel included in the process. We want them to be included in the process, and it helps us understand their needs so that we make sure that we're matching the device and the technology and the components to help them achieve those goals.
It is amazing what they can do now with some of those prosthetics, and I can't imagine the advancements we'll have ahead. I mean, have you guys had much experience with some of that, or?
Yeah, I've had a patient, a farmer, who had a bad injury to his hand and ended up with an amputation, and was ultimately working with a prosthetist, able to get a prosthesis where he could control fingers on the hand and allow him to continue to farm. Is really remarkable.
That's great. That's great. You know, we were talking a little bit about carpal tunnel syndrome there, but there's also cubital tunnel syndrome. Matt, what is cubital tunnel syndrome?
Yeah, so carpal tunnel and cubital tunnel syndrome both affect your hand. And typically they both can affect your hand while you're sleeping at night. And so, like David was saying, people wake up and they shake their hand out and kind of move it. And usually carpal tunnel is it's numbness and tingling to the thumb, index, long finger, and sometimes the ring finger. Cubital tunnel is a nerve that gets pinched, and instead of getting pinched down at the wrist or the carpus, it gets pinched at the elbow or the cubit. And so this nerve runs down. It's your funny bone nerve, the nerve that you hit when you hit your funny bone and sends electric shock down to your small finger and ring finger. It's a compression of that nerve at that elbow that causes numbness and tingling in the small finger and the ring finger. And the people also complain of weakness in the hand. It doesn't feel like they can button buttons really well or hold the cup very well. Things slide out of their hands because they don't have the grip strength anymore.
Sometimes surgery is done for that.
Yes.
Have you found that to be helpful? Do you Do you do that surgery?
I do that surgery. There's things you can do for it. Typically, if you're asleep and it's waking you up at night, there's splinting. There's putting a pillow in front of your elbow. So like David was saying, we curl up like this, and this is how we sleep. And when you curl up like that, it pinches that nerve in the elbow and makes it fall asleep. But you can go in, make an incision right over that nerve. And there's multiple different surgeries for this, and there's pros and cons of each surgery. But you can release the tissue that is around that nerve, so that nerve can wake up, and so the nerve can send signals back down to your fingers so they don't feel numb to us.
That's great. That's great. We were just kind of getting into arthritis some, and I think we've got some slides that we could show about arthritis in the hand.
Yeah.
Go ahead and tell us about arthritis a little bit more, and I think we've got the picture there now.
Yeah, so this is a bit of a subtle finding, but if you compare the joint in the middle finger knuckle to the ring finger knuckle, the space between the bones is less. So part of the arthritis problem is a wearing out of the cartilage. I oftentimes tell people it's like the tread on your tires wearing thin. And as that cartilage wears, the bones become closer. And so when someone comes in with hand pain, one of the ways that we differentiate, is this coming from a tendon problem, like a trigger finger or a tendinitis, or is it coming from arthritis, as with an x-ray? And when we see narrowing of the space between the bones, that points to the pain coming from arthritis.
The old bone-on-bone
thing. Exactly.
And of course, some people might be feeling that right now with the weather changing and the snow coming. I've become a believer of the barometric pressure.
Absolutely.
And how sometimes arthritis pain flares, and sometimes more women have babies. In that situation, I'm honestly definitely see that happen. So for arthritis, particularly in the hands, what do you recommend?
Yeah, so similar to some of the other conditions we've talked about, oftentimes we start with non-operative treatment. I always tell my patients there are some conditions that are better treated sooner rather than later, and that would be some of the nerve conditions that we were talking about, carpal tunnel or cubital tunnel. You don't want to wait too long for that. Arthritis, how aggressive we are in treating it is really driven by the symptoms, how bothersome it is. So simple things that we use are things like topical anti-inflammatories. There are medications like Voltaren gel that is like Advil or Aleve, but it comes in a tube, like a tube of toothpaste, and these joints in the hand are just beneath the skin, and so oftentimes just massaging that in can provide some relief. Sometimes wearing splints to immobilize a joint while you sleep allows that joint to rest and recover. Moving up from there, you can do cortisone injections, which I always tell people don't cure the arthritis, but can provide some relief for a while and allow them to live life with less pain. And ultimately, when those things aren't providing adequate relief, then we start thinking about doing surgery. And most people have heard about hip or knee replacements. Not everybody knows that there are joint replacements that can be done for the smaller joints in the hand and the wrist as well. So there are options. I oftentimes see people who have been told or just assume that arthritis in the hands is just part of getting older and you just got to live with it. But there are options we can do to keep people functional.
Good. I think we can go to the next slide and look at the rest of your pictures.
Yeah, I've got a few pictures of some of the different joint replacements that we do in the hand and the wrist. So on the far left here, this was for that patient with arthritis in the last diagram. You can see this is a metal joint replacement, and similar to a hip or knee replacement, it is replacing the joint with two synthetic surfaces, so that rather than bone on bone, it's two smooth surfaces. There's also a silicone joint replacement in the second picture here, and that can be done either at the knuckle at the base of the finger or at the middle joint in the finger. And again, the principle is the same. It's replacing the bone, rubbing on bone with a synthetic surface.
Yeah, it's fascinating. I mean, you definitely always hear about hip replacements and knee replacements and shoulder replacements, but even with the
small
fingers.
joints can be replaced.
Yeah. This person asks, is there a test for arthritis you can conduct without going in to see a physician?
There are signs and symptoms of arthritis. The best test is the x-ray. So you can see if there's bone on bone. But if you have swelling of a joint, if you have pain, sometimes you can feel grinding. Sometimes the joint looks larger. Or if you start losing motion in a joint, sometimes those things are symptoms of arthritis. But the best test is the x-ray.
Yeah. Yeah, I mean, you know, you can have that kind of grinding, or you can hear it or clicking and stuff too. But, you know, I'd caution if someone had redness and swelling, you know, could it be rheumatoid arthritis? And we'd want to know that and find that out to treat that differently. Or if there's an infection in a joint and it's red and swollen. So, might be best to get it checked out, perhaps.
Yes.
Yeah.
Certainly a sudden change in the pain is something that is always a little bit more concerning. So a joint that was mildly painful that now is all of a sudden suddenly painful and real red and hot, that's something that we would definitely want to have checked out sooner.
This person asked, do the physicians have any recommendations for how older adults can exercise but feel less pain after doing so? Are there recommended medications or a better regimen to follow? What would you say to that, Matt?
There is, when you exercise, there's a burn of the muscles that you get, and that's from buildup of some molecules in the muscles that cause those muscles to kind of ache a little bit. Having that kind of burning feeling is okay, but I think that if you're going to exercise and if you're going to go and work out and try to work through pain or work through severe pain or work up to pain, or you get done working out and you're experiencing continued pain after your workout, there's something probably going on. You're either working too hard, or you're not doing the exercise quite in the most effective way, or you might need to change the way or the type of exercise you were doing.
Yeah, yeah. You know, a lot of people like to run, but sometimes running can really put some wear and tear in the body, and it might be time to bike.
Yes.
Or
swim,
or, you know, take a load off and put a little bit less weight.
Correct.
On those joints, perhaps.
Correct.
Yeah. This rancher wants to know if he can get relief from calcium buildup in his hands causing pain by using painkillers, or if he would need surgery. So he's talking about calcium buildup in the hands, which could be arthritis.
Could be arthritis.
Could be gout.
Exactly. So absolutely, you can start with some of the simpler things that we talked about. Like I said, I'm a big believer, big fan of the topical anti-inflammatories. You can start with things like that. Sometimes warm soaks on the hands can be helpful, give people relief. It's probably difficult to actually get rid of the calcium buildup or the bone spur, that sort of thing, in a non-operative manner.
Yeah. This person asks, have our physicians ever heard of radiation therapy for Dupatrins disease before contractures form? Do they think it could be beneficial? What is Dupatrins?
Yeah, that's a good question. So Dupatrins is one of the conditions that we see, and maybe one of the less well understood conditions. It is a hereditary condition where the fascia, or the dense fibrous tissue under the skin in our palms, begins to thicken and form cords and nodules. And so oftentimes patients notice a lump in their palm, or maybe see kind of a rope-like structure. And as that progresses, that can begin to pull the finger down. Unfortunately, many things have been tried to prevent the progression of arthritis. Most of them have not been successful. I usually tell patients it's going to do what it's going to do, and there are treatments that we use to manage it, but things like splinting and radiation and therapy and exercises have not been shown to be real effective in altering the course of how that cord grows or tethers the finger.
And then, you know, I understand there's a newer treatment with the injection.
Yeah, so historically the gold standard for treatment of Dupatrins, if it begins to pull the finger down to where you're not able to get your hand flat on the table or get your fingers all the way out straight, was surgery, where you would surgically excise that abnormal tissue, and by doing that, that would allow the finger to come out straight again. These are a little bit bigger surgeries with bigger incisions on the hand, which require a little bit longer recovery. So about 10 years ago, a new treatment was developed. It's an injection. It's an enzyme which basically dissolves that cord. And so it is a procedure we do in the office where we just numb the hand up and inject a small amount of this medication into that cord. And that medication begins to soften the cord, and patients come back a day or two later, and we numb the hand again and are able to stretch that finger out straight, and that cord ruptures or allows the finger to return to a normal position again.
Yeah, it is remarkable. My father-in-law had that done, and they injected it, and it got better. I know of radiation treatment for that. I know they're studying that. Have you had much experience with that?
I haven't, and I'm not aware of anyone in our area that is doing that. So,
yeah. This caller, who had a meniscus tear knee surgery in July, is still having pain in the knee, is wondering how long she should expect the pain to last. Matt?
That's a good question. So I'm going to step back from that question and say, okay, some people don't know what a meniscus is.
Thank you.
And so in the knee, you have your thigh bone and your shin bone, and you have two C-shaped structures that sit right on top of the shin bone. And they're small structures, but they're very important. They help provide some lubrication to the knee. They help provide some stability to the knee. They also help cushion the lining of the joint, the cartilage. Meniscus can get torn if usually the two main types of meniscus tears that I see are either what's called degenerative. In other words, we've walked and walked and walked and walked, and our meniscus sees so much load on it day in and day out for 50, 60, 80 years of our life. And our body parts sometimes wear out, and so the meniscus can get torn. The other time I see people is if they're doing a big activity and they plant their foot and twist, and that meniscus can get torn from that, and those are the two main types. Meniscus tears are all different. There's many different types of meniscus tears. Sometimes when you have these degenerative meniscus tears, so you've walked it on all your life and they kind of tore by itself, sometimes those are associated with some cartilage or the lining of the joint, some cartilage issues. In other words, there is a meniscus tear, but there's also some wear of that cartilage. And so taking part of that meniscus out that's torn should help somewhat of the knee sometimes if there's no cartilage wear. So if somebody has wear of that cartilage and they've had part of that meniscus taken out, they could continue to have some pain in the knee because of that loss of cartilage that they have in the knee, or the lining of the joint that's a little bit more roughened in.
Can you repair meniscus?
Yes. Sometimes. The meniscus is an interesting structure. About a third of it has great blood supply, and we heal by blood. The blood comes in, and the blood sits there, and the cells in our blood help restore or help reattach our bodies together. There's part of the meniscus that just doesn't have a blood supply, and so there are times when I can go in and sew the meniscus back together, and it can heal. But if it's torn in a place where it doesn't get blood supply, then it's not going to heal, no matter what I do.
It can be so hard to visualize what we're talking about.
Yes.
Thus, we're going to bring Play-Doh into the
I
discussion.
love Play-Doh.
On a lighter note, let's watch a couple of orthopedic procedures using Play-Doh. That's right. California dermatologist Dr. Jessica So painstakingly recreates anatomically accurate body parts in Play-Doh so her curious preschooler son can practice mock surgical procedures. First, a total hip replacement, then a fibular fracture for your enjoyment.
Beautiful.
I'll do a little bit deeper.
Okay, go ahead. What do you see in there? A capsule. Okay, so the first thing we have to do is to dislocate the femur. Make sure that that socket is nice and smooth. Good job. It's probably good enough, right? Oh, a few more. Okay.
Can you see the cup?
Sure.
I think that is the most enjoyment of 20 seasons that we have had on a roll-in before. That was really entertaining. And from what I'm told, pretty realistic.
Pretty realistic.
Remarkably accurate for being done with Play-Doh.
Yeah, right down to the hammer and the
And the reamers and the plates and the screws, and a 6-year-old can do it.
Exactly, exactly. A caller from Mobridge who had issues with her fingers bending and popping. In the past, she's had injections to help with the issue. She was wondering what could be causing this issue in the first place.
Yeah, so there are a couple things that can cause popping in the fingers. Certainly the joints can, so popping your knuckles, if you press on your joints and you get a popping sensation, oftentimes kids will pop their knuckles, sometimes to bother their parents, but...
Does that cause arthritis?
It does not, no.
Okay.
That's a great question. There have been a number of studies, so I always tell kids when their parents ask them that, if their parents are okay with them popping their knuckles or cracking their knuckles, I'm okay with it.
Okay,
but,
that's good to know.
Probably the most common cause, though, of a popping or snapping sensation in the fingers is a tendon problem we call a trigger finger, where the tendons that bend the fingers down swell or thicken and develop a nodule, kind of like the callus on your skin. It's a thickened area of the tendon. And as you move your fingers, the tendon glides back and forth, and at the base of each finger, there's a tunnel that tendon runs through. And when there's a thickened area on the tendon, as that tendon glides through that tunnel, it can cause a catching or locking or clicking sensation. Oftentimes that's worse in the morning and with activities like wringing out a washcloth or forceful gripping or squeezing. So could be the joint. More commonly, though, that's a tendon problem.
Yeah, there was another person that asked a caller from Sioux Falls is wondering why they're experiencing trigger finger in different fingers.
That's a good question, too. Oftentimes people ask, why did I get this? I always tell people the short answer is I don't know. There are several medical conditions that predispose people to trigger fingers, things like diabetes or thyroid problems. Certainly when we do a lot with our hands, repetitive, forceful gripping can trigger it. Oftentimes, though, it just comes out of the blue, and there's not a clear cause or clear reason why someone got it.
And what can we do about it?
Yeah, so sometimes people try things like anti-inflammatories, maybe wearing a little splint on the finger at night. If that doesn't take care of it, oftentimes we use a cortisone injection. And I always tell people, unlike a cortisone injection for an arthritic joint, which we never expect to cure the problem, and cortisone injection for a trigger finger, a tendon problem, oftentimes does cure the problem. So I usually encourage people to try at least one injection. Ultimately, if it continues to bother, there's a little surgery that we do for it.
Yeah. Pretty low risk surgery.
It is. I sometimes tell people it's about as small a surgery as you can have. It takes about 5 minutes.
This person asked, do our physicians do robotic hip surgery in their clinics? Maybe not in their clinics. It would be in the hospital.
Yes.
But robotic surgery with most of the major joints is pretty commonplace now, right?
Correct. Yeah, we have robotic surgery for the knee as well as for the hip. I personally don't do those surgeries. I don't think David does. He does great finger work with surgeries that he's seen. I use a robot as an assistant for my shoulder replacements, and so I found that to be very beneficial and very helpful to make sure that the components, the pieces that we're putting in, are put in the appropriate way and appropriate place. So it takes the guessing out of it.
Is it faster recovery at all too, or not?
I'm going to say probably not, but it makes sure that the components are in the appropriate place, and so we're hoping that by putting them in what we feel is the appropriate place, that the longevity, the lifetime or the lifespan of that hip or that knee or that shoulder will last. And so instead of having to go back and do another replacement and another replacement, that it's just one and done.
So it's more exact.
Exact.
Yeah, where they might do a CT scan ahead of time to get the measurements down to the millimeter. Yeah.
Yeah. So yeah, with shoulder replacements that I do, I usually have my patients get a CT scan as well as an X-ray to make sure that we know exactly the morphology, the shape of the bones, and so then I can template. In other words, I can prepare before surgery and know exactly where I'm putting on a computer the pieces that I'm putting in and making sure that they fit appropriately in the patient.
That's great. This hiker is wondering what he can do about pain in his knee when he experiences while hiking.
While hiking. So there are things that you can do. So I think that if you're hiking, you're doing a lot of high impact loading of the knee. You're going up and down terrain. You're going through kind of mixed terrain. Sometimes before you go on a hike, you need to stay hydrated. You need to probably, sometimes have people take an anti-inflammatory like an Aleve beforehand. Shoe wear is very good. So different orthotics that you can put in the shoe, gel pads in the shoe to take some of that impact that the knee sees off.
Yeah, and would your
poles?
Hiking stick,
yeah, hiking sticks, poles are great because that's another way you can keep your balance. Your knee doesn't have to twist as much when you're going over that rough terrain, as well as you can put some weight on that and take some weight off your knees.
But the best part is this person's being active.
Love it.
And that's good for the joints in the long term too.
Correct.
Yeah. This caller who has a bone spur in one of her hands is wondering if it's possible to remove a bone spur without removing the bone that it is on.
The short answer is yes. Sometimes the results of that are disappointing though, because it doesn't completely remove the arthritic joint. So if the pain is just coming from the bone spur, yes, occasionally we will go in and just remove the bone spur. But oftentimes something more needs to be done to the joint to get rid of the ultimate cause of the pain coming from the arthritis.
Yeah. A caller who has an index finger that sometimes cramps up and causes pain is wondering if this could be caused by age or working outside a lot or a combination. So an index finger that's cramping up. Are you thinking trigger finger still, or?
Probably not. It
Okay.
sounds more like a muscle cramp. A trigger finger is a pretty obvious. When you make a fist, that finger kind of sticks down like this.
Yeah.
And if that's the case, yes, then the treatments we talked about for trigger finger before, if it's more just like a Charlie horse you get in your leg where the finger kind of wants to spasm, there are not surgical treatments for that. So it's similar to the treatments you probably described for people for cramps, staying hydrated, electrolytes, stretching, things of that nature.
Have some Gatorade or Powerade or
Gatorade or
something.
Powerade, exactly.
Sure. The caller's wondering if he had a tear in his rotator cuff 20 years ago but never saw a physician, if he could get that repaired now.
Oof, that is tough. It depends, I'm going to say.
Yeah.
So what we know about rotator cuffs is, like we already said, they're not going to heal by themselves. If it is a small rotator cuff tear 20 years ago, if it continues to be a small rotator cuff tear, centimeter, 2 centimeters big, sometimes you can get it back. However, after 20 years, oftentimes those tendon tears have gotten bigger. The other thing is tendons are attached to muscle. So it goes muscle, tendon, bone. And if you've heard that phrase, if you don't use it, you lose it,
yeah.
That's what happens sometimes. In other words, if that tendon is not attached to bone and that muscle can't pull, you're not using that muscle. And after 20 years, that muscle tends to atrophy, gets smaller. And there's a time period along the life of your muscle, if it's not being activated, if it's not pulling anymore, that muscle turns to fat. And even going and trying to repair it after 20 years, I might be able to get it back to the bone and it might attach to the bone, but if you don't have any muscle that's working, it's not going to help.
Now maybe for some physical therapy might help make his remaining muscles stronger.
Correct.
Now he could have frozen shoulder.
Yes.
After all these years.
Yes.
What is frozen shoulder?
Now, that's an excellent question. It is something that with the shoulder, you have your ball in the socket of the shoulder. The socket comes from the shoulder blade, the ball from the upper arm bone. Surrounding the ball and socket, keeping the ball and socket together, you have a lining of tissue called your joint capsule. And sometimes frozen, so let me go a step back. With frozen shoulder, that capsule becomes thickened and tighter, and with that capsule becoming thickened and tighter, the motion in the shoulder goes down, and people get what's called a frozen shoulder. They can't move their shoulder. They get stiff. It gets painful. Typically see this with people who are diabetic, sometimes thyroid disease, sometimes people who have had pacemakers put in get it. Frozen shoulder, thankfully, is a self-limiting disease. In other words, that over time, that capsule thaws out and relaxes out, and shoulder motion continues to improve. And the mainstay of frozen shoulder is therapy.
Yeah.
Let's get your shoulder moving again.
Couple quick questions here before we're out of time. What are our physicians' thoughts on fusing the bones in an arthritic hand to help get rid of the pain? Do you ever just fuse them?
Absolutely. It really depends on the joint. So the knuckles out at the tips of the fingers, if those are painful, oftentimes a fusion is the treatment of choice there.
And this caller has an enlarged knuckle that has recently started being painful. She is wondering if she should be worried about rheumatoid arthritis.
Yeah, so that's a great question. I have seen patients where their diagnosis of rheumatoid arthritis started with just a single joint. Oftentimes, though, that's more involved where there are joints throughout the body that are inflamed or swollen and painful. So I guess the short answer is if it continues to bother, it's probably worth getting checked out.
And that they could do a blood test for
Absolutely.
and everything.
Absolutely.
In our final minute, closing thoughts or recommendations that you'd love to tell all your patients all at once.
Stay healthy. Eat good. Get good exercise. Sleep well. Have a hobby you love to do.
Excellent. How about you, David?
I think the goal of orthopedic surgery is really keeping people doing what they enjoy doing. If there is pain that's interfering with your life and making the things that you would normally love to do painful, get it checked out, because for most of these joint issues, there's a treatment that can keep you active.
Yeah, we want to keep people active and healthy and moving and enjoying life.
Correct.
Love it. The winner of our drawing tonight is Jamie from Mobridge. Thank you, Jamie, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
Hallelujah, let it shine with the glory of the Lord. Go on and shine, shine, shine. Hallelujah, you are filled with the glory. You are filled with the glory. You will shine with the glory of the Lord.
As a family physician living on the upper Great Plains, I have many patients of Norwegian and German descent. Thus, I am familiar with some diseases that are prone to affect people of Northern European ancestry. One such example is Dupatrins contracture. Dupatrins contracture is a gradual thickening of the connective tissue of the palm of the hand. It may begin innocently as a nodule in the palm or joint stiffness, which are common for anyone. However, with Dupatrins contracture, over time the fingers curl inwards and cannot be straightened. Cords can become visible in the palm of the hand. This is often a slow progression over several years and may or may not become painful. It can make it harder to grasp objects and use the hand in general. Sometimes called the Viking disease, Dupatrins contracture most often affects men of Northern European descent over the age of 50. Other risk factors making a person susceptible to this disease can include smoking, alcohol, manual labor, and being thinner. It would seem being a fan of the Minnesota Vikings may be a risk factor, but that is probably just coincidence. The condition is named after Guillaume Dupatrin, a French military surgeon who was skilled in anatomy. He described the condition well and was the first to perform a successful operation for it in 1831. Interestingly, Dupatrin gained prominence from treating Napoleon Bonaparte's hemorrhoids. Although a steroid injection or physical therapy may be helpful, in general, Dupatrins contracture cannot be cured, only treated. For a long time, surgery was the mainstay treatment, especially for more advanced cases. Surgery can involve cutting the fascia, the affected layer of connective tissue. A less invasive procedure involves using needles to weaken the thickened cords of fascia. In the last decade, a new treatment became available. Injecting the enzyme collagenase weakens the bonds in the collagen of the fascia, releasing the contractures. Extracted from the bacteria Clostridium histolyticum, the collagenase offers an effective, non-surgical option for treatment. I'm not sure what my Norwegian and German ancestors would have thought about injecting an enzyme from a bacterium into their hands. However, patients today appreciate regaining the use of their hands for daily activities and to clap and cheer for their favorite football team. A big thank you to our guests, Dr. Matthew Blake and Dr. David Jones, for volunteering their time to help us learn more about orthopedics. A reminder for all of us, we are entering the influenza season here in the upper Midwest. If you are getting a COVID vaccine, it is safe to get the flu vaccine at the same time. Please make plans to get your flu vaccine and booster soon, before any family gatherings if possible. If you would like to see and hear more episodes of this program, please like and follow us on Facebook and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. Thank you for joining us as we continue celebrating our 20th season of truthful, tested, and timely medical information. From all of us here at On Call with Prairie Doc, until next time, stay healthy out there, people.
Have been in the news for their amazing reaction to the COVID pandemic. But when you call 911, who is sent to help? Who responds when you call 911? Next time on Call with the Prairie Doc, celebrating our 20th season.
Hello, my name is Dr. Ken Bartholomew from Pierre, and I serve on the Healing Words Foundation Board. This year we celebrate the 20th season of the Prairie Doc, created by my friend, the late Dr. Rick Holm. I watched as the Prairie Doc TV, radio, and newspaper programs were created, and now I watch as the legacy continues. Countless professionals donate their time to bring timely, trusted, truthful medical information free to the public without advertising, spin, or bias. As a native of Lemon, South Dakota, I realize how important this is, particularly to people in rural areas. You can help sustain the work of the Prairie Doc. Truthful, tested, timely information for 20 seasons. Please consider a charitable gift to the Healing Words Foundation, a 501c3 corporation. Go to prairiedoc.org and donate today. And thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Vance Thompson Vision, Monument Health, Black Hills Medical Society, Brookings, Madison, Flandreau District Medical Society, Pierre District Medical Society, Yankton District Medical Society, Orthopedic Institute, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swiftel Communications.